Tonight, we will start new webinars on best publication of the Hepatology International. These are going to present one of the best papers published in the Hepatology International for the last couple of years. At the beginning, I would like to introduce dual targeting of PDL1 and PDL2 by PCEB1B-ACE1 via sponging HSA-MIR 1945B induces immunosuppression in hepatocellular carcinoma. These are published by a group of the Department of the Third World Special Treatment, Shanghai Eastern Hepatobiliary Surgery Hospital, Shanghai, China. Authors include Pei Fang, KG Chen, Xiaolan Liu, Aijun Li, Haifeng Liu, and Sabine Wu. So please get started your lecture.
It's the end of the message from Professor Mata.
Good afternoon, professors. It's our great honor to participate in this episode virtual e-learning seminar series organized by Asia Pacific Association for the Study of Liver Hepatology webinar. Our speech theme is an article entitled Dual Targeting of PDL1 and PDL2 by Episode-1 via sponging human microRNA 1945P induces immunosuppression in hepatocellular carcinoma, published 2 years ago in the Hepatology International. Hepatocellular carcinoma is the most common type of primary liver cancer in adults. As the poor outcomes of surgery, radiotherapy, chemotherapy, and targeted therapy, immunotherapy brings new hope for cancer treatment. Since 1909, the basic theory of tumor immunotherapy has been improved. The goal of the drug is to either increase immunostimulation or decrease immunosuppression, pushing the immune system past this equilibrium point where T cells reactivated into actor. Immunocheckpoints are protective. Immunocheckpoints are protective molecules in the immune system. Tumor cells can promote the growth of tumor cells by overexpressing immunocheckpoint molecules, inhibiting the human immune system response and escaping human immunosurveillance and killing. PD-1 belongs to a broad protein family as shown in the picture. Some members of this family play a role in stimulating T cell activity. Programmed cell death receptor 1, PD-1, is one of the immune checkpoints. PD-1 is expressed on activated T cells. Interaction between PD-1 and its ligands, PD-L1 and PD-L2, occurs in multiple steps of immune response. Earlier researchers showed that the activation of PD-1/2 ligands in hepatocellular carcinoma leads to a poor prognosis of liver cancer. LINK-RNA regulates protein encoding genes from the transcription and the post-transcription levels, thus involved in diverse diseases, including cancer. In our study, we identified LINK-RNA Episode-1b/S1 as a key regulator for the expression and the function of PD-L1 and PD-L2 in HCC. Our research question is, how are the expression of PD-1 ligands regulated in HCC? And how is the regulation of PD-1 ligand involved in the immunoinhibition in HCC? We found the scatter plot showing the positive correlation between PD-L1 and PD-L2 in tumor tissue from TCGA dataset. The heat maps shows the top 10 linked RNAs which have high correlations with PD-L1 and PD-L2. There was an overlap of 4 linked RNAs between PD-L1 correlated linked RNAs and the PD-L2 correlated linked RNA. PD-1b/S1 was highly related with PD-L1 and PD-L2 in HCC tissues as well as in normal control tissues. It suggests that PD-1b/S1 might be an important regulator of PD-L1 and PD-L2 in HCC. Thus, we focus on PD-1b/S1 in the current study. RNA-hash showed PD-1b/S1 expression in cytosol of HAM7 and HepG2 cells. Tuckman assay in HCC tissues and matched control tissues showed that human microRNA 1945P level was significantly reduced in HCC tissues compared to matched control tissues. Scatter plots shows the negative correlation of human micro 1945P with PD-1b/PD-L1 protein level and the PD-L2 protein level in HCC tissues. PD-1b/S1 knockdown reduces the protein levels of PD-L1 and the PD-L2 at the same time. In addition, lentiviral overexpression of PCD1BS1 increases the protein levels of PDL1 and PDL2 at the same time. In cell transfected with luciferase reporter vector containing PDL1 3-UTR, co-transfection with human microRNA 1945P inhibitor enhance the luciferase activity while mutation of predicted binding site ablution the effect of human microRNA 1945P inhibitor. So PCD1BS1 knockdown increase human microRNA 1945P levels. Isolated exosomes from HepG2 cells was purified. The results shows that a green fluorescent dye labeled exosomes were located in the cytosol of HER7 and HepG2 cells. Pigment assay showed PCD1BS1 level in exosomes derived from HepG2 cells after PCD1BS1 knockdown. The results show that exosome from scramble infected cells reduce human microRNA 1945P level and increase the protein levels of PDL1 and PDL2. It suggests that blood exosome PCD1BS1 might be a non-invasive biomarker to monitor PDL's expression in HCC patients. Co-culture with HCC cells, overexpression PCD1BS1 increased early apoptotic T cells, while co-incubation with PDL1 and PDL2 blocking antibodies eliminated this effect. Labeled exosomes were mainly located in the cytosol of macrophages and the T cells. Exosomes from scramble infected HCC cells activated capsid activity in macrophages and the T cells, while exosomes from PCD1BS1 knockdown HCC cells had no such effect. In vivo and the in vitro experiments shows PCD1BS1 knockdown inhibited cell proliferation, colon formation, and tumor formation. Western blots and the quantification results showed that mTOR signaling proteins were reduced by PCD1BS1 knockdown. In contrast, pathways like Wnt, STAT, Notch were not affected. Our research showed that Episode-1 link RNA is a key regulator of PD-L1 or PD-L2 expression and function in HCC. It might be feasible to target Episode-1 in near further to evaluate its therapeutic potential in HCC. And thank you for your listening.
Thank you very much, Dr. Bean. It's a very elegant, bit complicated, well done studies. Let me ask the one small question that what can be the clinical significance of these studies? Actually, you mentioned that you can measure these long non-coding RNAs in the blood, and then that may correlate with the expression of the PD-L1, L2 in hepatocyte. So if it's used as biomarkers, that can be wonderful clinical applications. How do you think, Dr. Fang or Dr. Wu? Are you there? This is Dr. Mata from Tokyo.
Yes.
Yes,
We're here. We're here.
So please, clinical significance of these studies, measuring the exosomes, long non-coding RNA in the blood, that may tell there is a lot of PD-1 or PD-L1 expression in hepatocytes, and that helps for the introduction of the IO or ICI treatment. How do you think? And then, of
We
course,
want some
of course,
translation.
this non-coding RNA can be a target of the treatment, potential target. Is that right? Very important study. Cited almost 50 times already. Wonderful job. Congratulations. So because time limited, maybe better change to the next presentation, George Lau. How do you think?
But this is actually a very important study, and I'm so happy it's published in Hepatology International, and no wonder it is highly cited, because we are all trying at this time to find a biological marker for the response and who will be given the immune checkpoint inhibitors. And I think that we should give an opportunity for Professor Fan and Professor Wu to a response to Professor Omata's comments. And actually, Professor Zhou Jian is here. He is the mentor of both the key speakers over here. Professor Zhou, maybe you want to make a comment. 周院长在吗？
You know, I think many people talking about the expression of PD-L1, PD-L2, but what's controlling above it?
Yes,
very unclear. So this is touching upon that aspect.
It's very good.
Which is a very important subject.
吴斌在，吴教授，你的意见怎么样？你这个是很重要的 study， 因为我们有机会可以I'm sorry, I speak in Mandarin now.
No
because it is, I think this is very important point because we are all looking for biomarkers to guide our therapy. And I think Professor Martin made a very important comment. I would like to see your response, Professor Wu Bing. What do you think, and what is your plan in the future for translational medicine? And you have a chance to look at those patients who respond to immune checkpoint therapy.
Yeah, exosomes in the blood, they may contain this long non-coding RNAs.
Mm-hmm.
And actually, you mentioned that in your paper.
Yes. 就是现在这个在临床方面应用这个有没有肝癌病人接受跟对 immune checkpoint inhibitors 有反应的有没有差异的？就在临床方面这个做这个 RNA 的测试。
临床上的暂时还没有开展。
现在实验室还正在做。
They are making progress. They are making progress because I think they have a lot of hepatocellular carcinomas and PD-1, PD-L1s antibody, and also CTLA4 is coming into the pictures, and they can collect quite a huge numbers of samples to see who responds to these therapy. And this will facilitate our future approach to systemic therapy for hepatocellular carcinoma.
Yeah, please convey my message to Chinese colleagues, because Hepatology International is very much welcome this sort of the wonderful study from China. And then today it was presented in Chinese, but maybe next time you better make the slides in English, even though I can read some of them, but many of the audience can read it. So do that, please, next time.
Yes, this is a very important study. We understand in Asia Pacific, we have different language, and I need to congratulate Professor Martin and Professor Sarins to make everything manageable with the different dialogues. This is undoubtedly an important studies, and maybe we should move on. But last but not least, I really want to congratulate you again, Professor Wu Bing, for this excellent work. And I hope that we can do some transform and develop some new diagnostic assay.
I definitely join George Lau about this. Congratulations.
Okay.
Definitely.
And you will receive an award from APASL for the best paper of Hepatology International. Congratulations.
All right. Congratulations.
Yes.
Thank you.
Wonderful. See you in Shanghai.
Yes. And
Yes.
Professor Zhou Jian is here. Actually, Professor
Yes, sir.
Professor
Welcome.
Zhou Jian, he is the mentor.
I was in Shanghai from 1979.
Okay. Yes.
Before
You
you were
have big
born.
change. Yeah, big
Yeah.
change in Shanghai.
I met
China.
Tan Zhao Yu in Shanghai Tasha, 1979. Tan Zhao Yu.
Yes, Professor Tato, Professor Tato now
All right.
is
Good.
swimming every day. Even
Yeah.
he's 90,
All right,
93
Dr.
years
Zhou.
old.
Yeah,
Yes.
Dr. Zhou.
Yes.
Yeah,
Welcome you. Welcome you.
All right.
Welcome Shanghai.
Yeah.
My teacher, Professor Tato Yu, and my boss, Professor Jia Fai, welcome you.
Yeah.
Welcome you.
All right.
Yeah.
Okay. Good.
So
Maybe
we should move on, because you can see how I'm a Shanghainese too. I'm very happy the Shanghainese is dominating the sessions for hepatocellular carcinoma. Our next articles publications for this webinar is entitled Land in Combinations with TACE for Unresectable Hepatocellular Carcinoma, which is a retrospective control study. And the presenters will be the Professor Fu and Professor Q. So may I have the presenters to give the talk on this wonderful article published in Hepatology International 2020. Are they here? Professor Zhou Jian 他们在吗？
徐正强在吗？
我们在的。
再见。
对。
OK。
正强呢，你来 present 这个 data 啊，恭喜你。
谢谢。Thank you for Professor Liao. Now I will share my PPT, and that I can recorded this afternoon.
对。
You can start your presentation.
听不见。
There's no voice.
Yeah, you can talk. 坚强，你可以。
翟建强，我听不到你的声音啊！你的声音要打开，翟建强。
是吧？哎，
对，
听不到声音吗？
现在可以了，现在可以了。
现在有了。
但我录制的时候，我这有声音，是不是那个？这是我的录制的那个。那实在不行，我共享声音。对，
就自己讲吧。
行，我先试一下，实在不行我自己讲。
Now, no. The systemic treatment
现在有吗
for advanced HCC.
现在可以，现在可以，现在可以了。
那我
你重回。
那我从头开始。
The incidence of HCC in China accounts for half of the world. And the HBV infection as the main causes, the staging and the treatment pattern are different between the Eastern and the Western guidelines. So the people in China have poor prognosis. Guideline of CNLC staging system, we can perform tests from stage 1B to stage 3A. From the bridge study, in China, test was the most common first and second treatment for HCC. Now, the limitation of interventional therapy, we can find reduced response right after repeated treatment. Repeated test treatment may damage liver functions, and the survival rate still needs to be improved. So new treatment strategies are urgently needed with limitation for interventional therapy alone. The systemic treatment for advanced HCC from sulfonyl to IGRT. In the previous prospective or retrospective studies, the efficacy of TEST plus sulfonyl therapy in the treatment of advanced HCC were different. Lenvatinib was non-inferior to sulfonyl for OS, but provided a better response rate. The potential benefits of lenvatinib plus TEST, we can find the lenvatinib inhibits not only the expressions of VEGF1, 2, 3, but also inhibits the expressions of FGFR1, 2, 4. Lenvatinib as the initial treatment beyond up to 7 critical and child proof A liver function, middle strand HCC PTS, we can find that the lenvatinib is associated with better OS and high ORR. A potential treatment strategy to enhance the efficacy of lenvatinib or TEST for an suitable HCC combined treatment. So propose we conduct a retrospective controlled study to compare the efficacy and safety of combined treatment with lenvatinib and TICE versus TICE only in patients with unresectable HCC. So we enrolled 120 patients. The TEST and plus lenvatinib group are 60 patients, and the TEST only is 60 patients. The study endpoints are ORR, PFS, and OS. Baseline clinical characteristics of patients with unresectable HCC. The two groups are well balanced. Survival outcomes. OS and PFS were longer for patients in the test plus lenvatinib group than for those in the test group. OS was longer for patients in the test plus lenvatinib group than for those in the test group in total population and subgroup. The PFS was longer for patients in the test plus lenvatinib group than for those in the test group in total population and subgroup. The tumor response, according to the unrestricted criteria, the ORR in the test plus lenvatinib group was 68%. The test only is 31%. Biomarkers. The IFP and DCP levels were significantly decreased after treatment in most patients in both groups. Liver function, most patients maintained their liver function in the test plus lenvatinib group and the test group. The addition of lenvatinib to test therapy could significantly decrease the number of test sessions required and extend the interval time, which could be helpful for maintaining liver function. Safety, manageable safety profile for unresectable HCC in both groups. The most common AEs are decreased LB, hypertension, and decreased PLT. Conclusion, our suggested combination treatment with test and lenvatinib offers a superior trend for prolonging the survival of patients with unresectable HCC compared with test alone. The addition of lenvatinib to test therapy could significantly decrease the number of test sessions and extend the interval time, which could be helpful for maintaining liver function. The combination treatment had an acceptable safety profile without unexpected safety signals. Lenvatinib plus test may represent a potential treatment option for patients for unresectable HCC. Issues and confirmation of efficacy and safety in phase 3 RCT studies. Differentiation population, BCLC B or C, the timing and order of combination therapy, exploring the efficacy and safety of triple therapy in the area of immunotherapy. In the past 2 years, some data on TKA plus tests are reported. The Texas L trials suggest that the lenvatinib plus test shows high anti-cancer activities. The ongoing phase 3 studies of systemic treatment plus local treatment for intermediate HCC. The launch study shows the patients can benefit from the lenvatinib plus test. They can prolong the median OS and the PFS. The ongoing phase 2 or 3 studies of systemic treatment plus local treatment for advanced HCC. So at last, I should thank OT members of Department 2 of Interventional Radiology, EHBH. Thank the reviewers for their valuable comments and suggestions. And thank you MSD China for its assistance. That's all. Thank you. That's my.
Congratulations to the wonderful talk. And as you know, most of our patients with hepatocellular carcinomas presented at the intermediate stage and benefits from TACE. And your study shows that the additions of LAN might improve further on the patients. So at this point, I would like to ask whether the panelists and the others audience would like to make a few comments or any questions for this wonderful study.
Yes, I can make some words first. So actually, first congratulations on the publishing of this wonderful retrospective controlled study. Actually, we all know combination now combination therapy with local regional therapy combined with immuno or even combined with TKI drug is very common in China now in the clinical treatment for especially for advanced HCC. So it is expected for your study that the combination is better than the single treatment. As Dr. Zhai has showed us that another launch phase 3 study, RCT study, showed that TACE plus lenvatinib is better than the lenvatinib alone. So your study is TACE plus lenvatinib is better than TACE. So actually, this study shows your study and the launch study, which published last year, all showed that the combination therapy is better than the single therapy. So not only, actually, this phenomenon is not only can be seen in the HCC, actually in the ICC, cholangiocarcinoma is also the same. So like Topaz-1, immuno plus chemotherapy is better than the single chemotherapy. Our recently study, phase 2 study showed the chemo plus immuno PD-1, and then plus lenvatinib, as showed the 3 combination treatment shows 80% of OR, maybe the highest 80%, but the patient can tolerate the side effect. So I think combination treatment will be a treatment trend for not only HCC but also cholangiocarcinoma. That's my comment.
Thank you.
So any response from our wonderful young author? It's really happy to see young people coming into the hepatology world. So any response to Professor Chow's comments? Okay. In fact, I want to add one more question. And now we are having more and more therapy available as a systemic therapy. And in 2023, we now have a new immune checkpoint inhibitors. So whether you would consider the additions of immune checkpoint inhibitors in addition to TAS for your patients, and whether you have any ideas about how they will respond. Because from the Himalaya studies, so you can see do immune checkpoint inhibitors prolonged overall survivals and benefits from all other subsequent therapies, and whether this would enhance the response to TAS. And so you have any projects on this area?
Yes, we have some phase 2 study, the double immunotherapy, like such a PD-1, PD-L1 plus CTLA-4, or even PD-1 plus TIGIT antibody. So the double immunotherapy is now in the ongoing phase 2 study. For some is for the second line treatment for those patients after their resistance, after progression.
Okay, any further comments? If not, I would like to take this opportunity to thank all the participants for this first episode of Hepatology Highlights, aiming to recognize the best publications in our official journals. Hepatology International was established in 2007, and with the editor-in-chief being the Professor S.K. Saring and Professor Omata and the editorial board. And this is without their hard work, so it would never be successful. Now we have an impact factor of 9, and I hope that more contributions will be provided by the young people like you, the two presenters in this webinars to us, so that we can propagate and learn more and how we can benefit our patients. So if there is no further comments, I would like to close this webinar sessions, and thanks for everybody joining us this afternoon. Thank you very much. Professor Oshumi, yes, Professor Kudo is here. You want to make a comment, Professor Kudo?
On the previous talk?
Yes. Because you are the expert, you are the world leaders in land.
Yes.
Without your voice, we cannot close the session.
Actually, I'm in the middle of travel, so I'm in the taxi, but I'll make one comment. The speaker, I want to ask the speaker, the lenvatinib was introduced before first taste or after first taste? That's my question, because Tactics L single-arm phase 2 study we conducted in Japan. The upfront lenvatinib for 2 weeks achieved a very high complete response rate, around 68% complete response rate, because lenvatinib has activity of vascular normalization, and drug delivery is much improved. So upfront lenvatinib treatment for 2 to 3 weeks improves complete response rate. So in intermediate stage, not the advanced stage. So, but I saw in the slide, the intermediate stage complete response rate was 12%. So how did you introduce lenvatinib? Before first taste or after taste?
那就是问你这个做人法替理，还是在介入之前，还是在介入以后？
介入以后，we use lenvatinib after test within 3 to 7 days.
Because you showed the vascular normalization or drug delivery or interstitial pressure is improved by lenvatinib. So why not introduce lenvatinib upfront before first taste?
Maybe I make some explanation.
Okay.
Maybe maybe the patient cannot wait after lenvatinib, because I know in our hospital and even in their hospital, the patients cannot wait. Maybe after lenvatinib, maybe 1, 2 or 3 weeks later, the patient can come back to you, maybe to another hospital.
Yes, this is our experience too.
I see.
They are very nervous. Professor Kudo, they are very nervous. They want to be treated right away.
because this is a small meeting, so I need to tell the truth. Maybe.
Yes.
But there is no waiting list for taste. We give lenvatinib during the time the taste is scheduled. That is around 2 to 3 weeks.
Yeah, our Chinese colleagues works very hard, so the waiting time is much. we don't have a lot of waiting time. Almost right away.
Okay, Professor Kuda, how about combination? How do immediately Because today to before or two, 1 or 2 days before test, that is maybe can be practicable. 1 or 2 days before test.
2 days.
After the patient, is too early.
I see.
Too short. Maybe too short.
Preclinical data show 4 days in animal study. 4 days in lenvatinib, normalize the tumor vessel and improve the interstitial pressure. So maybe 4 days might be enough.
Might do better.
Yeah,
better.
better. Yeah.
Okay.
We will try to improve. And Professor Kuda, thanks for excellent comments. You see, we cannot even close the session without your comments. So how important you are. And I think that we need to go by now. It's 5:48, and we have 2 excellent presentations. And thanks for all your support. And we look forward to see you all in our next webinar on the Best of Hepatology International 3 months down the road, and that will be on MARFA. Thank you very much. Thank you, Professor Chow from Shanghai, and our Shanghai colleagues and our Japanese colleagues and the other colleagues are coming in. Thank you very much. I would like to close the session. Thank you.
Thank you.
Thank you.
Thank you very much.